Epistaxis. Introduction. Epistaxis is defined as acute hemorrhage of the nostril, nasal cavity, or nasopharynx. It's a very common condition that can present as a life-threatening emergency. Epistaxis can be unilateral or bilateral. The site of bleeding varies with a number of factors, including age, sex, anatomical and pathological abnormalities, occupation, climate, etc. Both external and internal carotid arteries supply the nose. The dividing line between the areas supplied by them is the upper part of the middle turbinate. Above this line, the blood supply to both the lateral wall and the septum is mainly from the internal carotid artery, whereas below this line, the blood supply is mainly from the external carotid artery. The majority of the blood supply to the nasal cavity is by the sphenopalatine artery, and is more commonly involved artery in epistaxis. Hence, this is called the artery of epistaxis. Younger individuals, particularly below the age of 40 years, commonly bleed from the anterior aspect of the nose. In contrast, people above this age bleed more commonly from the posterior aspect of the nasal cavity. Epistaxis is rarely seen in infants. Vascular anatomy of the nasal cavity. A rich vascular supply underlies this thin mucosal covering. Nasal erectile tissue results in a large number of venous sinuses, arterial venous anastomoses, and venules. Multiple arterial vessels fed by the high-pressure carotid system course through the nose. The respiratory mucosa, with its underlying vascular supply, serve to regulate heat exchange and humidification during respiration. The nasal cavity is basically supplied from two main sources. 1. Branches of external carotid artery. A. Sphenopalatine artery. B. Greater palatine artery. C. Superior labial branch of the facial artery. 2. Branches of internal carotid artery. A. Anterior ethmoidal artery. B. Posterior ethmoidal artery. These arteries intercommunicate in a rich plexus. There are two areas that are often implicated in nosebleeds: Kiesselbach's plexus, giving rise to anterior bleeds, and Woodruff's plexus, giving rise to posterior bleeds. The Kiesselbach's plexus is situated in the Little's area and the anterior-inferior part of the nasal septum. This plexus is contributed by four arteries of the nasal septum, namely 1. Sphenopalatine artery. 2. Greater palatine artery. 3. Superior labial branch of the facial artery. 4. Anterior ethmoidal artery. This plexus is the commonest site of bleeding, 90% of cases. Woodruff's plexus is located over the area posterior to the middle turbinate and is made up of anastomosis between branches of the internal maxillary artery, namely the posterior nasal, sphenopalatine, and ascending pharyngeal. The maxillary sinus ostium serves as the dividing line between the anterior and posterior epistaxis. Anterior bleeding is usually easier to access and is, therefore, less dangerous. Posterior epistaxis is more difficult to treat, as visualization is more difficult and blood is often swallowed, making it more difficult to gauge the amount of blood loss. Etiology of epistaxis. A. Local causes. 1. Congenital. Hereditary telangiectasia, Osler-Weber-Rendu syndrome. 2. Trauma. Microtrauma by nose picking, common in children, facial and skull base fractures, foreign body in the nose, including myiasis, iatrogenic trauma, barotrauma. 3. Inflammatory. Infective rhinitis. 4. Specific. Acute infection like diphtheria. Chronic granulomatous conditions. Tuberculosis. Leprosy. Syphilis. Rhinosporidiosis. Rhinoscleroma. Wegener's granulomatosis. 5. Nonspecific. Viral common cold, influenza, etc. Bacterial secondary bacterial rhinosinusitis. Fungal rhinosinusitis. Atrophic rhinitis. 6. Neoplastic. Benign juvenile angiofibroma, angioma of the septum, capillary and cavernous hemangioma, inverted papilloma, etc. Malignant, squamous cell carcinoma, olfactory neuroblastoma, nasopharyngeal carcinoma, etc. 7. Miscellaneous causes. Deviated nasal septum and spur. It causes eddy air currents and dryness of the nasal mucosa and crusting. Localized dryness and crusting and rhinitis sicca. Spontaneous rupture of tortuous arteriosclerotic vessels. Rhinolith. 8. Physiological causes. High altitude, extreme cold or hot climate. Classification of epistaxis. Anterior epistaxis. When blood flows out from the front of the nose with the patient in a sitting position. Posterior epistaxis. Mainly, the blood flows back into the throat. Patient may swallow it and later have a coffee-colored vomitus. This may erroneously be diagnosed as hematemesis. The difference between the two types of epistaxis are tabulated here. In the anterior epistaxis, incidence is more common, whereas in the posterior epistaxis, incidence is less common. Anterior epistaxis occurs mostly from Little's area, or the anterior part of the lateral wall, whereas posterior epistaxis is mostly from the posterior superior part of the nasal cavity, often difficult to localize the bleeding point. Anterior epistaxis mostly occurs in children or young adults, whereas posterior epistaxis occurs after 40 years of age. Cause of anterior epistaxis is mostly trauma, whereas the cause of posterior epistaxis is spontaneous, often due to hypertension or arteriosclerosis. Bleeding in the anterior epistaxis is usually mild and can be easily controlled by local pressure or an anterior pack, whereas in the posterior epistaxis, bleeding is severe and requires hospitalization, and the postnatal pack is often required. Evaluation of epistaxis. In acute active epistaxis, priority is given to control the bleeding before doing the investigations to find out the cause. Hypovolemia and blood loss should be promptly dealt with. Vital signs should be regularly monitored and concentration is given on the following: volume status, blood pressure, adequacy of airway, oral and nasal examination. Detailed medical and treatment history is taken as the patient is being managed and the bleeding is controlled. Anterior rhinoscopy. This is the mainstay of evaluation. With a good light source using a head mirror or headlight, the nasal cavity is inspected using a nasal speculum. Special attention should be paid to the plexus areas, as these are areas that often bleed. In case of active bleeding, a suction cannula may be used to determine the site of bleeding. Sometimes a cotton applicator may be used to find the bleeding point. Local anesthetic and vasoconstrictor may be required for better visualization and manipulation. If the bleeding point is identified, cauterization, silver nitrate of the bleeder, or anterior nasal packing may control bleeding. Posterior nasal packing may be required if the bleeding is from the posterior part, as in hypertensives. Alternatively, a Foley's catheter, or nasal balloon, may be used as a tamponade to control the bleeding. Posterior rhinoscopy. Posterior rhinoscopy is often difficult, but is helpful in recurrent mild epistaxis or blood-stained nasal discharge following neoplasia, rhinosporidius in the nasopharynx, or fungal sinusitis. Nasal endoscopy. Nasal endoscopy is a very useful tool in identifying and treating the bleeding point, especially so in difficult cases where the bleeder is too posterior or superior. Radiological evaluation. 1. X-ray paranasal sinuses helps in ruling out infective, traumatic, and neoplastic conditions. 2. CT scan is more useful in such cases. 3. Digital subtraction angiography is more useful in identification of the bleeding vessels in profuse and recurrent epistaxis. Embolization of the bleeder may be done selectively. Hematological investigations. Complete blood picture including clotting and bleeding profiles, blood grouping and cross-matching, blood counts including total platelet count. Management of epistaxis. Common local causes to be looked for in children include Little's area bleed, bleeding from retrocolumellar vein, foreign body, etc. In adults, the common causes include hypertension and other systemic illnesses. Once the site of bleeding has been located, the following steps can control the bleeding. General assessment of blood loss should be done and observed for hemodynamic changes and hypovolemic shock. It's important to replace the blood loss promptly while managing the epistaxis. In any case of epistaxis, it is important to know 1. Mode of onset, spontaneous or fingernail trauma. 2. Duration and frequency of bleeding. 3. Amount of blood loss. 4. Side of the nose from where bleeding is occurring. 5. Whether bleeding is of anterior or posterior type. 6. Any known bleeding tendency in the patient or family. 7. History of known medical ailment, hypertension, leukemia, mitral valve disease, cirrhosis, and nephritis. 8. History of drug intake, analgesics, anticoagulants, etc. Steps. Compression of the nostrils for 5 to 10 minutes. Pinching of the nostrils applies pressure over the lateral wall against the nasal septum, thus tamponades the bleeding site. Patient may be put in the sitting position, with the head bending forwards with mouth open. Trotter's method. He breathes quietly through the mouth and spits out the blood that collects in the pharynx. This will usually stop the active bleeding arising from the septum. Sometimes, after this step, application of cotton wool soaked with vasoconstrictor can be helpful. Placement of ice cubes over the bridge of the nose may hasten vasoconstriction. If this fails to control the bleeding, the next step should be anterior nasal packing. Cauterization. If the bleeding stops or reduces, the bleeding point may be cauterized using chemical or electrocautery. Chemical cautery may be done either with 20% silver nitrate. 3% trichloroacetic acid may be more effective because of its more caustic nature. Anterior nasal packing. Technique. This is usually done by using roller gauze, 1 meter long, soaked in liquid paraffin, Vaseline or bismuth iodoform paraffin paste. Under vision, using a long-bladed nasal speculum and Tilly's nasal dressing forceps, the nasal cavity is packed with multiple loops placed in horizontal or vertical layers from below upwards, stepladder fashion, as shown in the figure. The pack may be kept for 2 to 3 days. Bismuth iodoform paraffin paste pack can be kept for a longer period. Alternatively, hemostatic agent like gelatin sponge, Marasil, or Surgisil may be used. Gel form provides both tamponade to the site of bleeding and also promotes clot formation with early sealing of blood vessels. It need not be removed as it gets absorbed. Prophylactic antibiotics should be used if pack is in a place for more than 24 hours. A balloon tamponade may be used as an alternative to anterior nasal packing. This is less traumatic and is best suited in epistaxis due to bleeding or clotting disorders. Morbidity is less as it has a breathing tube. Posterior nasal balloon may be inflated if bleeding is from a posterior aspect of the nasal cavity and nasopharynx. Posterior nasal packing. Technique. This is required in rare instances and can be life-saving. This is usually indicated in posterior bleeding. Hypertensive epistaxis, bleeding, following angiofibroma excision, etc. are the common indications. A small gauze piece is rolled into a thumb-sized pack and 3 threads are tied to it, 2 at its ends and 1 in the center. The pack is soaked in liquid paraffin or bismuth iodoform paraffin paste. 2 rubber catheters are passed through the nose and brought through the oral cavity. Each one is tied to the corresponding thread of the pack. The catheters are pulled through the nose, and this brings the pack into the nasopharynx. It's kept in place at the posterior end of the septum. The threads are tied against the columella after guarding it with a piece of rubber. The thread tied at the center of the pack comes out through the mouth, which is strapped at the cheek. This thread aids in removal of the pack, which is usually done after 24 to 36 hours. Alternatively, a postnasal balloon or Foley's catheter may be used as a tamponade in the postnasal space or the nasal pharynx. Management of causes. Local causes can be managed transnasally endoscopically. In cases of recurrent episodes, the primary underlying cause should be evaluated to rule out systemic conditions and treated accordingly to prevent further episodes. General measures in epistaxis. 1. Make the patient sit up with a backrest and record any blood loss taking place through spitting or vomiting. 2. Reassure the patient. 3. Keep a check on the pulse, blood pressure, and respiration. 4. Maintain hemodynamics. A blood transfusion may be required. 5. Antibiotics may be given to prevent sinusitis, if pack is to be kept beyond 24 hours. 6. Intermittent oxygen may be required in patients with bilateral packs because of increased pulmonary resistance from nasal pulmonary reflex. 7. Investigate and treat the patient for any underlying local or general cause. Surgical intervention. This is necessary if the epistaxis is refractory to the conservative measures. Following surgical methods may be tried. 1. Nasal endoscopy assisted bipolar cauterization under general anesthesia may be done to coagulate the bleeder. 2. Nasal cautery. 1. Chemical cautery with a bead of silver nitrate is helpful in cases of mild bleeding. The tip of silver nitrate stick should be held in contact of bleeding site for several seconds. The cauterized area becomes grayish-white in color. Mild anterior nasal packing should be done after cauterization. 2. Electrocautery. Monopolar, bipolar, or suction cautery. It's employed in cases of failure and severe bleeding. Topical anesthesia with 4% xylocaine and then local infiltration with xylocaine adrenaline are used before cauterization. 3. Endoscopic nasal cautery. Posterior bleeding points are seen and cauterized better under endoscopic vision. With the help of suction cautery, the procedure may be done successfully under local anesthesia and sedation. 4. Complication. Avoid deep and bilateral cautery, as they can cause septal perforation. 3. Ligation. Ligation of the artery may be required only in refractory cases where bleeding fails to stop after packing, tamponade, anterior and postnasal. A. External carotid. When bleeding is from the external carotid system and the conservative measures have failed, ligation of the external carotid artery above the origin of the superior thyroid artery should be done. It's avoided these days in favor of embolization or ligation of more peripheral branches of the sphenopalatine artery. B. Maxillary artery. Ligation of this artery is done in uncontrollable posterior epistaxis. Approach is via Caldwell-Luke operation. Posterior wall of the maxillary sinus is removed, and the maxillary artery or its branches are blocked by applying clips. This procedure is now superseded by transnasal endoscopic sphenopalatine artery ligation, replacing the sublabial transanteral approach. Transanteral clipping or ligation of the internal maxillary artery may be done by sublabial pterygomaxillary fossa approach. C. Ethmoidal arteries. In anterosuperior bleeding above the middle turbinate, not controlled by packing, anterior and posterior ethmoidal arteries, which supply this area, can be ligated. The vessels are exposed in the medial wall of the orbit by an external ethmoid Lynch incision. Bleeding from the upper part of the nose, above the level of the middle turbinate, requires ligation or clipping of the anterior ethmoidal artery by external incision near the inner canthus. 4. Embolization. It's done by an interventional radiologist through femoral artery catheterization. Internal maxillary artery is localized, and the embolization is performed with absorbable gel form and/or polyvinyl alcohol or coils. Both ipsilateral or bilateral embolizations may be required for unilateral epistaxis because of cross-circulation. Embolization is generally a safe procedure, but may have potential risk like cerebral thromboembolism, hematoma at local site. Ethmoidal arteries cannot be embolized. 5. Transnasal endoscopic sphenopalatine artery ligation. The procedure can be done with rigid endoscopes under topical anesthesia with sedation or under a general anesthesia. A mucosal flap is lifted in posterior part of lateral nasal wall. Sphenopalatine artery is localized as it exits the foramen and closed with a vascular clip. Distal branches of the artery can be additionally cauterized and the flap then reposited. Anterior ethmoidal artery can also be ligated by Lynch incision as an adjunctive procedure. Sphenopalatine artery ligation gives high success in the control of refractory posterior bleed. Hereditary hemorrhagic telangiectasia. It occurs in the anterior part of nasal septum and is the cause of recurrent bleeding. It can be treated by using argon, potassium titanyl phosphate, or neodymium-doped yttrium aluminum garnet laser. The procedure may require to be repeated several times in a year as telangiectasia recurs in the surrounding mucosa. Some cases require septodermoplasty, where anterior part of septal mucosa is excised and replaced by a split skin graft. That's all for the video. We'll see you next time.